What thoughts come to your mind when you hear the words HIV and AIDS?
Well, it's a global, I would also almost say hysteria since more than 20 years, which has originated from the States but which has taken over in all other countries, has had a tremendous impact on a whole generation, has generated unprecedented funds, and has proved virtually all predictions which were made and in the past did not materialize. In the public debate and the media reports on HIV/AIDS, a lot of reports are very emotional since the very beginning, and a lot of reports are based on estimates which later don't materialize. And one very sad and cynical aspect in this debate is the debate about orphans. It's sad because orphans already they have a hard life. And it is my feeling that they are misused in this debate. And I would just like to draw your attention to a document from a WHO, which is called The Care and Support of Children of HIV-Infected Parents. And it is what WHO calls a restricted document. And inside of the document it reads, the contents of this restricted document may not be divulged to persons other than those to whom this has been originally addressed. It may not be further distributed nor reproduced in any matter and should not be referenced in bibliographic matter or cited. Now, I find it very difficult to understand why would WHO spend public money to do research in health issues and then restrict the result of their research. I would expect WHO to share whatever their findings are, whether it is contradictory or not, in order to help people on the ground to improve the health. And I think that's the perception of most people in the world, and that's what they expect from WHO. Now, if you look in the document, it is again very interesting to see what WHO writes about Uganda. And you come across a very interesting paragraph which reads, "There is confusion as to what is meant by the term orphan. In the Uganda enumeration study, an orphan is a child who has lost one or two parents. In brackets, the standard Uganda definition of an orphan." Now it's interesting to note that there are national definitions of what is an orphan. Projection studies carried out by WHO and studies done elsewhere have used different criteria, such as both parents only or both parents and or mother. The United Nations Children's Fund, UNICEF, defines an orphan as a child whose mother has died, and WHO defines an orphan as a child who has lost both parents or only the mother. And WHO continues to write, "One of the confusing aspects is the extent to which the absence of one parent is the norm even in a given society." And I would like to remind you that Uganda had a decade of civil war. And of course, one of the results of a civil war is that people are killed. And the necessary result is that you have orphans. So WHO doesn't take into consideration the reason for a child being an orphan. And it continues, there is also confusion over the term AIDS orphan. AIDS orphan can signify a child orphaned as a result of parents dying of AIDS, or an orphan child who is HIV positive or who has AIDS. And it continues, in the Uganda enumeration study, no distinction was made as to the cause of orphanhood, which in some areas included the effects of war. Now, it's very disturbing that even these very sad children are kind of being misused with artificial definitions to make it appear that whatever is the reason of their orphanhood, And even if they are not actually orphans, because one father or the mother is just absent for the moment, they are called and labeled AIDS orphans, and they appear in the published reports about AIDS orphans by WHO and other bodies. I just want to cite you another paragraph from the studies, from this WHO publication, where it says various definitions of orphans have been used in studies enumerating them. For World Bank purposes, they included the entire population of minors who have lost at least one parent, regardless of whom they are living with. But again, lost doesn't mean necessarily that this parent died. It is this person is just absent. And it is important to keep in mind that in some parts of Africa, it is a social standard or social norm that women have children from different fathers. So by definition, if you use this definition, these children are orphans. There is one important question in the discussion of HIV/AIDS, that is, are there patients sick with symptoms called AIDS who are HIV negative? In other words, is it possible that people have AIDS without HIV? And this question has never been answered in a satisfying way since the appearance of HIV. And there is one important document in this discussion, which was published by WHO in 1993, which is called a report of a scientific meeting on unexplained severe immunodeficiency without evidence of HIV infection. So this is a very important question in the scientific debate about HIV/AIDS. And as a clinician, I would be eager not only to read this document, but also to continue this debate and see and learn more about it. And in this respect, I'm kind of surprised that WHO judged this document as limited distribution and states inside that this document is not issued to the general public and should not be further distributed, which is sad from a scientific and clinical point of view. Now, if you look inside what they report on this meeting, is first they give an overview of reasons which could lead to immunodeficiency, like malnutrition, something very frequent in Africa, tuberculosis, several infectious diseases. Things we know since long time ago. It's nothing new, and it has existed before the AIDS era, and it still exists to this day. And consequently, the participants of this meeting, they came up with a number of cases, so-called AIDS cases without HIV. But the surprising conclusion of this meeting was that there is the recommendation number one is worldwide surveillance for severe immunodeficiency without HIV infection is not recommended. Now, this is surprising, especially when you go on and you read the reasoning. Is WHO or the members of this meeting, they state it is such a rare event, we don't have to look for it. Now, this is a circular argument. If you don't look for something, of course it is rare because you don't recognize it. You can recognize only something you pay attention to. So I'm afraid that there is a huge number of AIDS cases without HIV, but we don't know them because we don't pay attention and they are not reported. In 1985, the CDC in the United States came up with the first clinical definition of AIDS patients, how to diagnose AIDS patients, which was clearly not workable in resource-poor settings like in Africa. So in 1986, WHO published a definition which is called Bangui definition, based on specific clinical symptoms like fever, weight loss. And this definition is applied in most resource-poor countries like in Africa and other parts of the world.
And what is the problem with Bangui?
Well, the problem with Bangui definition, originally it did not necessitate an HIV test, and still in a number of countries an HIV test is not necessary to make a diagnosis of an AIDS patient based on this Bangui definition. But the biggest problem is that the definition is based on unspecific clinical symptoms when we know that there are no typical symptoms for AIDS. And even Luc Montagnier, Professor Montagnier, the discoverer of HIV, stated clearly there are no typical symptoms of AIDS. Now, how can you as a clinician diagnose a patient as being suffering from AIDS based on clinical symptoms when we know there are no typical clinical symptoms? When you go to poor countries, poverty translates into people being sick, frequently sick, and dying a premature death. So when you go to a poor country, you're confronted with many sick people, and mainly being sick from poverty-related diseases, like infectious diarrhea, like respiratory infections, or like tuberculosis. You have to keep in mind that in Uganda, about 50% of the population have no access to clean drinking water, which is the very basis of survival. So, of course, you frequently come across sick people presenting with exactly these symptoms like fever, weight loss, and diarrhea. Now, usually we were educated to treat them according to the underlying disease. If now, since '86, since WHO published this new Bangui definition, we switch to another definition saying, well, it is not an infectious diarrhea, it is something else called AIDS. There is a tendency and the risk, and that's actually what is happening on the ground, that we also switch the therapy. And instead of treating the underlying disease, we follow the label. Actually, we just give a new label to the patient. We don't have more sick people in Uganda. We don't see an increase in mortality. On the contrary. But we just give a new name to the disease, and accordingly we will give another treatment. Clinicians very, very fast realized the problems with working with this so-called Bangui definition, because a number of diseases have these unspecific symptoms, like diarrhea, infectious diarrhea, like respiratory infections or tuberculosis, which all of them are widespread in Africa. So in another African country, in Ivory Coast, doctors sat together and tried to improve the Bangui definition because they thought the Bangui definition had a poor outcome in clinical routine. And they came up with something called the Abidjan definition, which is kind of an amended Bangui definition. And a similar thing happened in Latin America when clinicians over there realized they had problems and with working with the Bangui definition because of the poor outcome. So they came up with another definition based on clinical symptoms called the Caracas definition. All of them tried to find a way to diagnose what we know as AIDS based on unspecific clinical symptoms, while all what we know about AIDS is there are no typical clinical symptoms. So the Bangui definition, which is based on very unspecific clinical symptoms like fever, weight loss, or diarrhea or cough, these are symptoms which are widespread in poor countries where people suffer from diseases, well-known diseases, with exactly these symptoms. Now, if these symptoms are widespread, it is virtually impossible to diagnose AIDS as different to other well-known and widespread diseases like infectious diarrhea or respiratory infections or tuberculosis. And just to give you an example, one of the problems people had is that weight loss in the Bangui definition is defined as 10% weight loss. Now, most people in resource-poor settings don't know their normal body weight because they can't weight, they don't take their weight. Now, if they don't know their normal body weight, of course they can't diagnose 10% weight loss. So even the very unspecific Bangui definition was not feasible, workable in these resource-poor settings. Well, in clinical terms, it just doesn't make sense. It is not helpful in any way. We are confronted frequently with sick people. That's our job, to treat them. In order to treat them in the best way, what we essentially need is to make the best diagnosis we can come up with, to treat them accordingly. And a diagnosis which is just giving another label to well-known treatable diseases doesn't help on treating these patients. Well, in Africa on the ground, and I experienced that personally, is frequently, especially you come to a situation when you don't really know the diagnosis of a given patient. That's normal, especially if you have very limited laboratory resources or diagnostic resources. So in the era before AIDS, we had to admit we don't know the diagnosis and we could hypothesize. But nowadays, what doctors do is, well, if we don't know what it is, it must be AIDS. And so a number of people become AIDS patients just because there is no alternative diagnosis which is obvious. And this diagnosis is very readily accepted by the patients because everyone knows that AIDS is around, but it is not helpful. And on top of that, what is very serious is there is a general perception if someone is diagnosed with AIDS, he's kind of lost, he's going to die anyway. So what is happening on the ground is if you have limited therapeutic resources, like limited number of antibiotics, and you have a patient which is diagnosed in AIDS, you would not give this patient the limited drugs you have, with the reasoning, why would I kind of waste these few drugs I have on a patient who's going to die anyway, instead of keeping these drugs for someone to treat someone who is not diagnosed AIDS, but just having an infectious diarrhea, for example. And so this is a very, very sad aspect of this general hysteria about HIV and AIDS, that it leads to people being neglected even if one could help them.
And what are the medical resources like in a country like Uganda? If somebody gets sick.
Well, the government is doing what they can, and the health professionals are very experienced and very dedicated to do what they can with the limited resources. But what we consider a basic laboratory investigation, like a blood count, is hardly ever feasible. Before you do a C-section, you don't do a blood count. So you really have to shift your whole thinking of what is a basic intervention and basic laboratory intervention. When you go to resource-poor settings, they just don't have the money for it. And definitely, to spend the little money they have for an HIV test might not be the health priority in most settings, because there are more urgent things to diagnose or to treat. Well, the Bangui definition is something WHO decided and recommended for resource-poor settings. But on top of that, when countries adopted this Bangui definition, they adapted it according to what they call their national needs. So if you go to different countries, what you come across is so-called nationally adopted versions of the Bangui definition. Just to give you an example, Uganda included in its definition for AIDS tuberculosis. So tuberculosis is an AIDS-defining disease in Uganda. But if you go across the border, Tanzania didn't follow that example, but instead they made it more restrictive. They required an additional sign of this out of this selection of unspecific symptoms. So there, even in a small regional context, you have different definitions of this very broad and unspecific definition of Bangui. And as a clinician, you really have to question whether this is of any benefit. Again, knowing that there are widespread, easily preventable and easily treatable diseases which can't be prevented and can't be treated because of financial restraints. Well, it's kind of difficult to understand where is this national need on this side or the other side of a border to change or adapt a clinical definition. You take malaria, there is no different malaria definition this side or the other side of the border. It's a given disease, we know the symptoms, and the treatments may vary, but the disease itself is recognized as the same everywhere in the world. So just to give you an example of the clinical use of this so-called Bangui definition, I went to the Ministry of Health in Uganda, in Kampala, and got the reporting form which doctors fill out when they declare an AIDS case to the Ministry of Health. And there it is clearly stated these major signs like weight loss, diarrhea, fever, or herpes or cough or very unspecific clinical symptoms. So based on these symptoms, AIDS is diagnosed in most places of Africa. And it's important to note that in Uganda, even on the reporting form, there is no space for an HIV test. Now, in some other countries in Africa, an HIV test is done routinely or in most cases, but in Uganda it's still not required. So in Tanzania, on the other side of the border from Uganda, they are using a more strict version, nationally adapted version of the Bangui definition, and asking for 4 clinical symptoms instead of 3 of the original definition. Nevertheless, in one of the annual reports, the Ministry of Health in Tanzania reports that only 33% of reported AIDS cases actually fulfilled these AIDS-defining criteria. And they continue to write, although 1,320 cases would not strictly qualify to be called AIDS cases, we have taken them as cases, assuming that those who reported them just made an omission at the stage of compiling the forms. So in other words, you start at a very unspecific, with the diagnosis with very unspecific clinical symptoms. Based on these symptoms, you report cases. Now the Ministry of Health counts as AIDS cases even patients who have not even fulfilled the criteria of these 4 very unspecific cases, and they count them as AIDS cases and further continue to report them to Geneva, and then further on estimates are added for underreporting. Now most countries use so-called nationally adapted versions of the Bangui definition, and some make it more strict, some make it less strict. Like Uganda, they added tuberculosis as an AIDS-defining disease, whereas Tanzania made it more strict and added also an HIV test, which was not originally part of the Bangui definition. And South Africa went also in the way making it more strict. This is the reporting form for AIDS cases from South Africa, when you can see clearly that an HIV test is optional for AIDS diagnosis on the reporting form, when the doctor who is reporting AIDS cases has to tick whether an HIV test has been done, yes or no, and if yes, the laboratory result. Now, if you take the example of Uganda, and Uganda is really very telling because some 10-50 years ago it was called the epicenter of the worldwide pandemic. And that's where everything kind of started. And we had a rate or estimate of about 15% of the total population being infected with HIV at that time. And of course, the underlying assumption was all these people will eventually die after an incubation period, get AIDS after an incubation period, then die. And now it's interesting if you go back to Uganda some 10, 15 years later, we face the very surprising finding that actually the population growth rate has increased. Uganda these days is one of the fastest growing countries in the world. And the reason for that is that mortality has not increased. It has been rather stable or slightly decreased, but fertility is still at a very high level. So instead of having a negative effect on population, we face a country which is rapidly growing. And this is just inconsistent with a deadly epidemic. In the end 80s, after the Bangui definition was published, it was meant to be applied in resource-poor settings. And of course, Latin America or parts of Latin America is among them. So clinicians there evaluated the Bangui definition and found it not really workable and very unsatisfying in clinical routine. Partly because their patients didn't know what their normal weight loss was, and so they couldn't evaluate whether they had 10% or more weight loss. And also, they did not see some of these clinical symptoms which WHO was referring to. So they came up with another, actually it was the third clinical definition of AIDS for resource-poor settings. And this definition was called Caracas definition. One of the very surprising findings of AIDS from a clinical point of view is that whenever you go to another country, you almost always find a new definition. And this is also true outside Africa. And when I went to Thailand and I went to the Ministry of Health in Bangkok, I again asked them for the reporting form of AIDS cases which is applied in Thailand. And I found it very, very surprising that one of the risk factors they state in their reporting form was having sex, period. So according to the Thai reporting and definition of AIDS, every person having sex, whatever kind of sex, is considered as having a risk factor for HIV and AIDS. Now, when we are faced with these reports of an epidemic of AIDS cases, we have to go into details and really see what does it mean. If we take the example of Uganda, there has not been an increase of dead people. There has not been an increase of mortality. What has happened on the ground is that patients who were sick, and some of them even died from well-known diseases, they got a new label, they got a new name, and they were called AIDS cases now, at least after the definition was introduced. And then you have other countries like South Africa, where you see an increase in mortality over the last years, which is reported by Statistics South Africa being due to an increase in tuberculosis. But again, you have the similar finding that tuberculosis frequently, or to a varying extent, is relabeled or called AIDS now. So when you come across these reports about an epidemic of AIDS cases, it does not necessarily translate in a new disease and more people dying from a new disease. Well, it's interesting if you go back to WHO and you talk to them about the Bangui definition, they will say, well, it was not meant in the beginning as being a clinical tool. So you can have very open and frank discussions about the limitations of applying this definition, this Bangui definition, in clinical routine. But then if you look at what is happening on the ground, this is exactly what is being done. And national ministries kind of took over this definition from WHO which was meant for surveillance purposes, and they create reporting forms for surveillance purposes. But in the end, of course, the clinician on the ground, they use them for clinical use. And they're not given kind of two definitions, one for surveillance, one for clinical routine. And that would be totally absurd. There is no other disease where you get two definitions, one for reporting and one for treatment. This is nonsense. What kills people in Africa? I think it is important to keep in mind, especially for us in the West, that poverty is not a romantic issue. It is a deadly issue. Poverty leads to diseases and premature death. Period. Full stop. So if you go to countries with what we call poor resources or poor countries, people are just suffering and dying prematurely. And you see all these kinds of diseases which were widespread in Europe, in North America, 2 or 3 generations ago. These are poverty-related diseases like tuberculosis, infectious diarrhea, and infectious respiratory diseases. This is widespread. We know them. We know how to prevent it. And malaria, it's in large parts of Africa. Malaria is another good example. Why don't we have a program to provide every citizen in Africa with a mosquito net? That would be easy, cheap, easy to achieve. It's hardly done. And I would like to cite a letter to the editor, to the newspaper, daily newspaper in Kampala, who one day said, why doesn't the West give us free mosquito nets instead of giving free AIDS treatment? And I think this reflects very much the need on the ground. And people on the ground, they know very well what they need. We just need to ask them and to listen to them. I think we need to understand that HIV/AIDS, especially in Africa, is kind of a white man's show. Or in other words, it's donor-driven. Those who have money, they define the priorities. If you talk to people on the ground, they need clean drinking water, the very basis of survival. And if they could make a choice, they would rather opt for clean drinking water than for condoms. Well, frequently the discussion is, why is HIV spread mainly heterosexually in Africa and not in other countries? And you come across very racist, very serious and mean statements, even from very high people like WHO, who bluntly state, well, it is because Africans have a deep-rooted polygamous sexual life, which, beside being ignorant and being racist, it's not evidence-based. And for example, the Durex condom company, they are doing regularly international sex surveys, and they found the countries with the highest number of lifetime sexual partners are the United States and France. And those countries which are most hit by HIV/AIDS, like Africa and Thailand, actually they have among the lowest number of lifetime sexual partners. There is a huge number of associations, international, national, non-governmental associations, scientists, doctors, who in one way or the other have an advantage of being engaged in HIV/AIDS. And this whole movement has succeeded to get an unprecedented budget over the last 20 years. Now, this would be nothing to bother about if we would have unlimited resources and if other healthcare priorities... Is that a problem? C'est bon! Now, this would not be a problem if This would not be a problem if we had unlimited funds and other healthcare priorities would still get the attention they need. Just citing another example like clean drinking water or maternal mortality or malaria. But that's not the case, unfortunately. We have limited funds, and especially in resource-poor settings, by definition, we have very limited funds. And what is happening on the ground is that the little funds we have, they are diverted to HIV/AIDS, and WHO even states that publicly and recommends even that. For example, at a conference in Addis Ababa with health ministers and finance ministers from African countries, WHO actually recommended to take resources from other budgets and to use it for HIV/AIDS. So my fear is, with all this knowledge and what I saw and experienced on the ground, that there is a risk that this focus on HIV/AIDS will hurt and have a negative impact on the health of people, especially in resource-poor settings. As a clinician, I have to rely on a number of information and resources because I can't verify every single biological test I'm using. But still I have to be informed, and I have to read kind of the information which is available in order to answer whatever question comes from my patient. And I'm getting a little bit worried when I read the product information of HIV tests, because in some tests, for example, from a well-known company in the United States, which actually produces the most widely sold ELISA test, they state that beside their test being very reliable, they state there is no recognized standard to establish the presence or absence of HIV antibodies in human blood. Now, I'm not a technician, but I wonder what that means if the company who is producing and selling the test is not even aware of how to verify the reliability of their test by admitting no one in the world, according to their knowledge, has any established recognized standard to verify whether their test is reliable or not. Just to give you a very stupid example, if I would use a pregnancy test and the package insert of the pregnancy test would say this is a very reliable pregnancy test, but there is no recognized standard of establishing the presence or absence of a pregnancy, I would be kind of reluctant to use the test, and I would wonder why the company is selling a test when they can't verify how reliable it is. And of course, there are means and ways to verify presence or absence of a pregnancy. We have a gold standard, so we can verify whether a test is reliable or not. And obviously, at least the main company in the world producing and selling these HIV tests is not aware of a recognized standard. I find that troubling from a clinical point of view. There are in the whole HIV/AIDS kind of discussion, public and the scientific discussion, there are a number of discrepancies and a number of things you discover when you're working in the field. And one aspect is, or one question is, are there people who turn negative once they have been positive? And the general perception is, no, that's not happening. And that's definitely wrong. And it happens more frequently in Africa, but it also happens in developed countries like in Europe. And I personally know a nurse who has been HIV positive a few months after a hepatitis B vaccination. And 3 years later, she turned negative. And she had no risk factor whatsoever. She was living in the countries, in a small city in Austria, having 2 children, no risk factor whatsoever, beside this hepatitis B vaccination. And she didn't get a clear answer, explanation why she turned negative after 3 years. And this is very disturbing. not the fact that there are contradictions happening, but what is disturbing that there is a tendency to pretend these things don't happen. From a scientific point of view, you would expect the exact opposite behavior. If there is some event, something happen against your expectation, you would be very excited and study this event, because that's where you can learn more about what the subject you are studying. But this nurse, instead of being studied, she just was turned away and asked to never come again back to the central hospital in Austria. So I personally am very worried about these small incidences. I try to always verify whatever I do and whatever I say in my profession. I think we owe this to our patients, to verify whatever we do and whatever we say. Otherwise, we can't keep up the highest standard in medicine. So the other way, I went to a lab and asked for the package insert, the product information of the ELISA test which they used. And I got it back and I went through it, and I was very surprised to find a statement by the producer that in a study, 40% of those people who had influenza vaccination turned out with a positive ELISA test. Now, if you keep in mind that influenza vaccination is quite widespread in a number of countries in the world, this is a serious risk of false positive test results. Now, we are aware that all biological tests are not 100% accurate, but we should exert some transparency, and especially when there is such a high risk of false positive results in such a common event like influenza vaccination. I think we should be aware and make people aware that this can happen. I think we owe this transparency and honesty to our patients.
So if a patient were to test positive for HIV, what would your recommendations be to them?
That's very difficult. If a patient comes up with a HIV positive test, I would recommend him to read carefully the information which is available, especially the information which is easily available, but not forgetting the information which is less easily available, like the package insert of the product information and the product information of the HIV tests. And we frequently talk about informed consent and what we in medicine. And what we mean about informed consent is that the patient has the right, and it is our duty as health professionals, to make sure that the patient gets the full picture, the full information on whatever situation he is in, and so that the patient is in a position to take an informed decision. And I think this applies also to HIV tests.
Some people are very fortunate they don't have these side effects. So